A question that I'm going to pose to you, I guess, from an educational perspective is that, the mutations come in various flavors, if you will. So there are point mutations, deletions, insertions, that sort of stuff. And I think there is some data out there that some may be worse than others. Do you have any comments about that part?
Yeah, there are some interesting studies that reflect on that information. I think for many of these mutations, it may portend a risk of developing metastatic disease. It may indicate differences in responsiveness to therapies. But the reality is we're either stuck with metastatic disease or it hasn't recurred. There definitely is influence on the treatment response to different drugs, which I think we'll come to in a few minutes. But I think that's probably the most important part for the mutational analysis. In addition to some of the risks for developing metastatic disease, which, as I mentioned, may be lower in PDGFR alpha mutant GIST, may be higher in SDH deficient GIST, but those tend to be really indolent tumors that can take many years to develop or to progress to clinically meaningful sizes.
Exactly.
So I think that the mutations have a lot of influence on the biology of the tumors, as well as on the responsiveness to therapies.
Absolutely. And the one example that we can highlight, I guess, again, is that while KIT exon 11 is the most common mutation that we will see, the specific deletion in exons 557, 558, for example, are clearly predisposed to developing later recurrence than usual, right? And these are the kind of nuances that come from larger experiences over a longer period of time. But that was a very good summary of the mutational analysis in this complex tumor that would appear to be simple on the surface.